Everyone, welcome back. Today we will study about Sjogren syndrome. Sjogren syndrome is autoimmune exocrinopathy which involve the exocrine glands of the body. This is autoimmune disease. In autoimmune disease we study like RA, SLE, MCTD, scleroderma. Okay. This is second most common autoimmune disease involving the exocrine gland. Okay, most common autoimmune disease is RA. Age group 20 to 40 year of age. Female is to male ratio. Like all other autoimmune diseases, female is to male ratio. This disease is more common in females, and female is to male ratio is 9:1. Other diseases which are associated with the female is to male ratio 9:1 is SLE, Kawasaki. Okay. Actually, Sjogren syndrome having two types: primary Sjogren syndrome and secondary Sjogren syndrome. In primary Sjogren syndrome, there is no association with any other autoimmune disease, and it is associated with HLA. Main HLA associated with this is HLA-DR3 and HLA-DQ-A10501. Two main HLA involvement in Sjogren syndrome. Secondary Sjogren syndrome is associated with any other CTD. Most common CTD associated with secondary Sjogren syndrome is RA. Actually, in RA, there is association. Most common symptom is keratoconjunctivitis sicca. Not always due to Sjogren syndrome. We will study it later. Okay? Not always due to RA. So, Sjogren syndrome. Then other causes are all other autoimmune disease, SLE, scleroderma, MCTD. In GIT, it is associated with PBC. Therefore, clinical significance of this is whenever a patient comes with Sjogren syndrome, you have always investigate her for LFT. Okay, we will see it later on. Then it is associated with chronic hepatitis C. This is very important. It is associated with chronic hepatitis C. That's why always undergo viral marker of the patient. Then it is associated with Hashimoto thyroiditis. This is very important. As Sjogren syndrome always involve the exocrine gland, and it is also involving one endocrine gland, that is thyroid gland. Therefore, always undergo T3, T4, TSH of Sjogren syndrome. Now, the genetic association in primary Sjogren syndrome. Important genetic association you should remember. This table has been taken from Kelly, and important genetic association associated with primary Sjogren is HLA. HLA mein important is HLA-DR2 and DR3, and then HLA-B8 and A24. Okay. Then you should remember about IR5, STAT4 and EBF1. Okay. Now the pathogenesis of Sjogren syndrome. Pathogenesis of Sjogren syndrome. There is periductal, and perivascular lymphocyte infiltration. Main pathology is periductal and perivascular lymphocyte infiltration by mainly, this is very important, CD4 T cells. Okay, and B cells also. Now B cell, function of B cells is antibody formation through the autoantibody production. Autoantibody production against one is alpha fodrin protein and second is M3 receptor. M3 receptor, main function of M3 receptor is Salivation, so there is dry secretion of gland because of autoantibody formation against M3 receptor. And first theory is this for dry secretion. Second theory for dry secretion is there is immune destruction by CD4 T cell. Immune destruction by CD4 T cell lead to acinar injury and fibrosis. Acinar injury and fibrosis, okay, which will lead to decrease in secretions of the gland. This is the diagram from the Kelly, which is showing the antibody from the B cell. This is the B cell. Okay? The autoantibody produced from the B cell against the M3 receptor. Now we will learn about the clinical feature of Sjogren syndrome. First of all, it involves the glands. So the glandular manifestations of the Sjogren syndrome and extraglandular manifestation of the Sjogren syndrome. In glandular manifestation, there is dry eyes, dry mouth. Sweat gland are also exocrine gland. So there is decreased secretion, decreased sweat formation, so dry skin, which will lead to pruritus. Intestinal gland are also exocrine gland, so it will lead to constipation. Okay, these are glandular manifestation. Most specific is dry mouth. Okay, patient will give symptom of red tongue, altered taste sensation, dental caries, and dry eyes and dry mouth. These both are the clinical hallmark of the disease. Next are the extraglandular manifestation of the Sjogren syndrome. Extraglandular manifestations seen in the 50% of the patient. Most common extraglandular manifestation is arthritis. Arthritis in Sjogren syndrome is like SLE, that is, it is non-erosive but deforming. But deformity reverses by joint position change by the person, that is Jacquard's like arthropathy. Why does it does occur? Due to laxity of ligaments. This is similar to the SLE. Next common manifestation. This is the table from the Harrison's. Next common manifestation is Raynaud's phenomena. Okay. In this, most common manifestation is arthralgia or arthritis. 60% of patients may. This is usually non-erosive and leading to Jacquard's arthropathy. Okay, then next is Raynaud's phenomena. Raynaud's phenomena is seen in 37. Second most common involvement is Raynaud's phenomena. Check is secondary Raynaud's phenomena. Actually, in 1/3 of the patient, this Raynaud's phenomena precede the Zika symptom in case of Sjogren syndrome. Okay, and this Raynaud's phenomena can lead to critical limb ischemia. Then lung involvement. Lung involvement is rare but is seen in almost around 14% of the patient. Most common lung involvement is NSIP, ILD. In all the autoimmune disease, lung involvement is NSIP, except for RA, in which lung involvement is UIP. It involves small airway of the lung. Most common lung manifestation is NSIP and patient present with dry cough and shortness of breath. Now the rare but specific manifestation of the Sjogren syndrome is lymphocytic interstitial pneumonia. This is most characteristic in the lung involvement. Lymphocytic interstitial pneumonia should be differentiated from HIV-associated lymphocytic interstitial pneumonia. We will discuss it later. Then is the kidney involvement. Kidney involvement, there is less because there is no involvement of vessels, so there is very less involvement of glomerulus, and there is no glomerular nephritis. Main symptom associated with kidney is distal RTA. Distal RTA is type 1 RTA. Most characteristic feature seen in distal RTA is hypokalemia. Okay, and metabolic acidosis and hypokalemia. We should undergo the PGA with serum electrolyte of the patient. Next is the liver involvement. Liver involvement is very important. This is associated with primary ciliary cirrhosis. Therefore, I told you, PBC, the most common association of PBC is Sjogren syndrome. But in Sjogren syndrome, only 6% of patients are having the PBC. PBC, there is increase in ALP level. So usually it is asymptomatic. Most common symptom is fatigue. So we should always undergo LFT of the patient. The next involvement is small vessel vasculitis, for which there are purpura arteriolar lesions. Then peripheral neuropathy. Peripheral neuropathy in Sjogren syndrome is bilaterally symmetrical sensory motor small fiber neuropathy. Bilaterally symmetrical sensory motor small fiber neuropathy, and it involves lower limb more than upper limb. That is stocking and glove pattern, just like diabetes. One important feature of Sjogren syndrome is having MS-like lesion in brain and spinal cord. One is associated with SLE, second is association with Sjogren syndrome. Both can have MS-like lesions. Okay, so this is known as Sjogren myelopathy. Then last but not the least, most important is association with lymphoma, that is maltoma. Maltoma is most common lymphoma associated with Sjogren syndrome. Okay, for autoimmune diseases association with lymphoma. All autoimmune diseases associated with lymphoma are marginal zone lymphoma. Low grade usually. Except, always there is exception with RA. That is DLBCL is most common. Okay. Now when we will suspect the marginal zone lymphoma, that is maltoma, in patient with Sjogren syndrome? When there is persistent parotid enlargement, we will come to diagnostic part, but we should know when there is anti-Rho and anti-La positive. Patient is coming with splenomegaly, lymphadenopathy, C4 level decreased, hypocomplementemia, leukopenia, cryoglobulinemia, and increase interleukin 18. This is very, very important. You should suspect maltoma when there is persistent parotid enlargement, anti-Rho, anti-La positive associated with splenomegaly and lymphadenopathy, C4 level are decreased, leukopenia, cryoglobulinemia, and interleukin 18 positive. Okay. Now this is also very important slide. Differential diagnosis of Sjogren syndrome. Very important, two differential diagnoses. One is HIV infection. Actually, in HIV infection and Sjogren syndrome. HIV infection, usually young male will come to you, HIV positive. There is Rho and La antibody negative. With, this is very important, I told you, CD8 infiltration of salivary gland. Here is CD4 infiltration. Its association with HLA-DR5. This is associated with HLA-DR3 and HLA-DRW52. Positive serological test for HIV, negative serological test for HIV. In sarcoidosis, there is no antibody ROLA. Very important finding in histopathological examination is granuloma formation in the salivary gland, and there is negative test for HIV also. Now, before coming to the diagnostic criteria for Sjogren syndrome, we will see about the antibody present in Sjogren syndrome, that is anti-Rho and anti-La antibody. Anti-Rho is SSA, anti-La is SSB. If these are positive, then it is primary Sjogren syndrome until proven otherwise. Except in case of SLA, where it is secondary Sjogren syndrome and Rho and La can be positive. For SLA, this is good if anti-Rho and anti-La is positive. Why? Because there is decreased risk of nephritis and vasculitis. Other characteristic feature which are related to Rho-La positivity is when the Rho-La positive in SLA, there is increased chances of subacute cutaneous lupus erythematosus. There is increased chances of congenital heart block in neonates. There are increased chances of shrinking lung syndrome in SLA. Increased chances of lupus myocarditis. And if Rho and La are positive in primary Sjogren syndrome, then there is early disease onset. There is longer duration of disease. More severe lymphocytic infiltrate. Okay. And then there is more chances of lymphoma. And there are more chances of extraglandular manifestation. Okay. In primary Sjogren syndrome, if Rho or La are positive, then there is early disease onset, longer duration of disease, more severe infiltrate, increased chances of lymphoma and extraglandular manifestation. Okay, what is the treatment for lymphoma? For lymphoma, rituximab plus choprazine. Okay. Now the classification criteria. ACR criteria for Sjogren syndrome. This is modified in 2016. First and most important, histopathology. Histopathological is the gold standard test for Sjogren syndrome. The site for histopathological examination is lower lip biopsy. There should be CD4 T cell infiltrate, as we have already discussed. You should not go into detail. You should remember focal lymphocytic infiltrate with focus score of more than 1. Only you have to remember this. Then the score is 3. Then presence of anti-Rho and anti-La antibody, anti-Rho antibody basically. Anti-Rho antibody, then score is 3. Then third is Sika ocular staining score more than 5. Using Lissamin green stain. Lissamin green stain. Actually we use Lissamin green stain. This is the diagram showing the Lissamin staining of the dry eye. There will be punctate staining of cornea if there is dry eye. Then we will undergo Shermer test. Shermer test less than 5. Actually Normal Sharma test is when it is more than equal to 5 mm in 5 minutes in at least one eye. If there is Sharma test positive in only one eye, then also score is 1. Okay. Then fifth is unstimulated whole salivary blood flow. Salivary flow of less than 0.1 ml per minute. Okay. Normal flow is more than 0.1 ml per minute basal secretion of the salivary gland. So if it is less than 0.1 ml per minute, then this test is positive. Rule for classification is patient may be classified as primary Sjogren syndrome if they display at least one symptom of ocular or ocular dryness and total score of 4 or greater when leave it. Now we will study about the treatment of the primary Sjogren syndrome. Primary Sjogren syndrome, when there is established diagnosis of primary Sjogren syndrome, that is either it is greater conjunctivitis sicca, xerostomia, extraglandular manifestation. What are the manifestation we have to look into? Like if patient is having dry eyes, then avoid harmful environment, tear, supplement, punctal occlusion, ophthalmic, cyclosporin we can give. If there is dry skin, we can prescribe skin moisturizers. If there is vaginal dryness, we can use vaginal moisturizers. Xerostomia, dry mouth, then candy, gum, saliva substitute, pilocarpine, cevimeline. We use pilocarpine 10 mg TDS, cevimeline we can use. And we should give treatment for oral candidiasis. Then is extraglandular disease. If there is extraglandular disease, we have to assess the severity. If there is mild severity, like arthralgia, arthritis, purpura, skin involvement, then we should give NSAID plus HCQ. And if there is moderate or severe intensity, like if there is involvement of ILD, like in RA, we should give CP pulse therapy, or we can give steroid plus MMF, CP pulse plus steroid. We can give rituximab. Okay, these disease modifying agent like methotrexate, azathioprine, MMF, cyclophosphamide, rituximab. These are given when there is either NSIP, LIP, interstitial nephritis, PNS involvement with motor weakness, systemic necrotizing vasculitis, CNS involvement with focal deficit or severe cognitive dysfunction. So this is all about Sjogren syndrome. Thank you very much.